Good evening. I'm Kelly Gear-Ripken, National Chair of A Women's Journey. On behalf of Johns Hopkins Medicine's A Women's Journey, thank you for joining us this evening for our monthly webcast series, Health Conversations That Matter. A Women's Journey always strives to improve your well-being through health education. According to the Celiac Disease Foundation, celiac disease is a serious autoimmune disease that occurs in genetically predisposed people, where the ingestion of gluten leads to damage in the small intestine. It is estimated to affect 1 in 100 people worldwide, but only about 30% are properly diagnosed. Tonight, we are pleased to be joined by nutritional gastroenterologist Dr. Gerard Mullin, who serves as the director of the Johns Hopkins Hospital Integrative GI Nutrition Services. So please use your Q&A on your screen to ask your questions to Dr. Mullin, who will respond during the last 20 minutes of tonight's conversation. Our webcast will conclude at 8 p.m. this evening. I want to take this opportunity to acknowledge and thank Johns Hopkins University's program Hopkins at Home for their production assistance. You can visit their website for additional lectures and courses throughout the year. And now I'm pleased to welcome Dr. Mullin.
Well, good evening. Hope everyone is enjoying this good weather. I enjoy good hot weather, so if you don't, I apologize, but it's a good day, good evening to be here with you, and of course, to speak for A Women's Journey, something I very much enjoy. So first, I'd like to show you that I don't have any conflicts of interest, which is important these days to disclose when we begin a lecture or begin a discussion in the medical field. But first, we're going to do this evening is talk about what is celiac disease and what is the natural history of the disease, what is the epidemiology, the genetics, the predispositions, the pathophysiology of disease, and what it can do to our bodies and in terms of long-term health. How do we treat it? And importantly, how do we monitor it once we have it? We have to understand also its interconnectivity throughout the body and to other body systems, and particularly to other autoimmune conditions. And finally, we want to touch on those burning questions about gluten and wheat and all these non-celiac issues that come up with gluten because of its popularity, the gluten-free diets, and what is the validity of that and what is the role for that. So to begin, let me first discuss, as Kelly had mentioned, that the prevalence of celiac disease is 1% that we know of in the US population. It's likely much higher, but at this point, we have estimated that the prevalence is 1%. Now, it's important to know about predisposing factors, and one of the most common links that we know of is the fact that there's a higher risk in first-degree relatives. So we advocate for screening of first-degree relatives of known celiac disease cases, and it can be across different generations that we see it in families. We do have risk stratification based on the presence or absence of symptoms. In other words, we have celiac disease, we have classical symptoms, but we also see a lot of vague symptomatology, which is why only maybe 30% of the people who have it are diagnosed at this point in time, because it can be a silent disease, it can be a subtle disease with very overlapping symptoms of other conditions. One thing we do know, which is kind of interesting, is that it's actually increasing in the population, both in the US and worldwide. And at least in the US, we know that it's increasing by about 7.5% per year. We used to think of this as a young person's disease, but we're seeing it even in the elderly population. And for those who are over 65 years of age, we're seeing 20% of diagnoses that are made in that population, which I think is very significant, even for doctors to be aware of, that we sometimes overlook symptoms that it can't be celiac because someone's 65, but that's not true. This is a condition, of course, being on Women's Journey, to understand that it's much more common in women than men. So we have to be on the lookout for that, particularly as providers. We'll talk about the ethnic predispositions, but realize that it's really a disease that began as being recognized in those of Northern European heritage, in Caucasians. but we do see it in other populations. So we have to also keep our minds open that no matter what race or ethnic predisposition someone has, that they could have celiac disease. It's not always in white European people. Okay, so this slide actually gives you a little bit of a pictorial representation of the prevalence of celiac disease, at least what we diagnose by antibodies, which is how with biopsies we diagnose the disease. And you can see, as I had mentioned, that in the darkest blue, navy blue, you can see the strongest prevalence being in Norway or in the Northern European regions. But also we do see pockets in other places of the world where there's a high prevalence of disease. Surprisingly, even in regions of India, that you can see pockets of celiac disease. So, giving you an expanded perspective, who gets celiac disease? Well, basically anybody can get celiac disease. So we have to keep an open mind to that. What do they present with? And if you look at this picture, look at all the conditions, early onset of osteoporosis, people who present with weight loss, people who present with irritable bowel syndrome type symptomatology and unexplained anemia can have celiac disease that could be overlapping, if not masquerading as other conditions. When can we see this? Well, we don't see it in the first year or two, right? Because it takes time after the exposure to gluten, but we could see it pretty much at any age, but in the average, it's around 45 years of age. But again, 20% of the people diagnosed are 65 years or older. And when do you develop celiac disease? It's felt to be around a decade after the onset of symptoms. So there's a delay in a diagnosis. And by that point in time, you can have an established disease with osteoporosis and other consequences. So it's a late diagnosis in the majority of people. This is what I had mentioned previously in terms of this growing incidence, this epidemic of celiac disease. So 1% doesn't sound much of an epidemic after what we all experienced with COVID, but take a look at this graph and take a look from 1990 on, that you could see that there is a rapidly growing increase in the incidence of this disease. So we know that for unknown reasons, it seems to be that it's growing and quickly growing in the populations, and unlikely due to the increasing recognition of the disease itself, because the antibodies to diagnose the disease have been around for many years. This is what we call the celiac iceberg. And what it means is that if we look at people and how they're diagnosed by antibodies, that there's a large population of people who have the disease and really don't know it. You could see the silent disease population, and only a certain amount of those people will become manifested by symptoms. So the minority of patients with celiac disease actually manifest these symptoms, and then eventually come to a diagnosis which requires a biopsy. And they become the tip of the iceberg. How do we diagnose the disease? Well, we'll go over some of the blood tests, the intestinal biopsies, and the combination thereof. But look, it is estimated that 83% of Americans who have it are undiagnosed. That's a lot of people out there who don't have the disease, who have the disease and we don't know at this point in time, largely because it's a silent disease, as I showed you in that iceberg. The majority of those people really don't know they have it because they're silent or their symptoms overlap with other diseases. That's the problem with this disease. So the question is, how does it develop, right? Is gluten necessarily the evil? So let me walk you through the pathogenesis and begin that part of the conversation. Is that what happens is that we all, or those who are not gluten-free, are exposed to this component called gluten, this complex peptide. And basically what happens is that our enzymes are only able to partially digest this gluten. It's partially digested, and basically what happens is that it gets presented to the gut, and this peptide itself can leak through the epithelial cells or is taken up by certain cells within the epithelial cells and undergoes deamidation by an enzyme called tissue transglutaminase. Tissue transglutaminase 2 is the enzyme which is really required to, let's say, reconfigure this peptide. And when it's reconfigured by tissue transglutaminase, it's taken up by an immune cell with this, what's called that HLA molecule, which is required as a cofactor for the, let's say, the gluten or the digested gluten that's partially digested to be presented to the immune cell together. So it requires a genetic cofactor. It requires that the gluten is partially digested and deamidated by the enzyme. And then once that happens, in this genetically susceptible host, it sets off this chain reaction. And this chain reaction has all these different little interleukins and cytokines that we hear about, and sets off this chain reaction, which includes the destruction of the epithelium. And it causes this barrier dysfunction or this leaky gut, if you've heard this terminology, and that allows even more of this partially digested gluten to come in. And it sets you up for a vicious cycle. The next slide shows it a little bit better, I would say. And the reason why I like this particular slide is that it focuses on this barrier and the dysfunctional barrier. And so for those of you who've heard about this part of the pathogenesis, that there's this molecule called zonulin. And zonulin is like a gatekeeper, and it allows one to regulate the barrier function. And in the setting of a stress response to gluten, this zonulin is released and the barrier becomes open and more dysfunctional and more gluten gets in. The important thing is that you can measure zonulin in the stool. Some people measure zonulin in the blood. Dr. Fasano up in Harvard, who used to be here in Baltimore at the University of Maryland in the Department of Pediatrics, is now at Mass General, has been there for a number of years doing research, and is looking at the role of zonulin and regulating zonulin in the pathogenesis and possible treatment of celiac disease. So if you hear a lot about zonulin and leaky gut and Alessio Fasano, that's why I'm focusing on this particular part of the pathogenesis, because it may lead to some therapies. Otherwise, the pathogenesis here is pretty complicated. But again, once we have this partially digested protein of gluten that undergoes deamidation, it sets off this immune chain reaction. And once you understand that better, then you can understand the different therapies that are being worked on in industry. So with that as a background, let's talk about how celiac disease can present. Well, it's interesting because I mentioned in the middle the classic manifestations that we have seen more in the pediatric populations are the full-blown diarrhea, malabsorption, weight loss, and even stunted growth in children. Failure to thrive as if they're in a third world country with marasmus and kwashiorkor, mineral deficiencies and vitamin deficiencies, which can be quite extreme, and also the malabsorption of fat or steatorrhea. So years ago, we thought this was the classic presentation for celiac disease, but in adults, it's in the vast minority of patients who present this way. The majority of patients are either silent or present on the left with these non-classical features. Iron deficiency anemia for us in the adult GI community is one of the more common ways that we have celiac disease on our radar. But even just having elevated liver enzymes of unknown origin is one way that celiac disease can present. It can have neurological manifestations, altered gait, neuropathies of the digits. You can have paresthesias that are related to celiac disease, seizures of unknown origin from celiac disease. And it goes on, even the irritable bowel syndrome-like symptomatology of bloating and fatigue, and also the stunted growth as I mentioned before, in children, but also osteoporosis of early onset is another clue. If you look on the right, it's important to keep in mind that we have these autoimmune associations. So if a young lady comes along and has Hashimoto's thyroiditis, you have to also keep in mind they may have celiac disease, that there's a higher prevalence. Microscopic colitis as well, higher prevalence of celiac disease, and a skin disorder called dermatitis herpetiformis, that celiac disease occurs in 100% of these patients. So these are the things we keep in mind as doctors when we see patients and we think about who may or may not have celiac disease. Are they at higher risk because they have a relative? Are they at higher risk because they have an autoimmune disease? Are they presenting with these full-blown syndromes that we see more commonly in children, but can also less commonly be seen in adults? Or do they have one of these conditions on the left that are more subtle, less commonly seen in celiac disease, but also seen in celiac disease? So it's complicated. And that's why we see so many people undiagnosed or underdiagnosed at this. It's a chameleon. It can masquerade as many conditions. So this slide says, well, okay, so we understand that there is extraintestinal manifestations of celiac disease. Well, we know that, but what is the impact of making early diagnosed? What can be reversed? So we know that if we intervene, that we can make the skin lesion, which can be quite awful, and I'll show you that in the next accompanying slide, is that it can actually be cured by a gluten-free diet. The anemia is reversible. Sometimes even the liver enzyme abnormalities are, reversible, and there's, variable responses to neurological and joint problems that can be seen. But the infertility is less predictable. We can see celiac disease present as infertility, and that has to be thought about in the fertility world, but also in also the GI and medical world. But the enamel defects that can occur with celiac disease less frequently respond. So that's why diagnosing early may make a difference. As I had previously mentioned, we have to keep in mind that we have this autoimmune association. If we see somebody with one autoimmune condition, there's overlaps, and they may be higher risk for other autoimmune conditions. And as you know, autoimmune conditions have a much higher prevalence in women than men, by and large. So here are the different conditions that we see a higher predisposition of celiac disease when there's an underlying autoimmune condition, as shown in this slide. This is dermatitis herpetiformis. And what happens, if you look on the right-hand side, is that it happens because we have this antibody attacking tissue transglutaminase 3 in the skin. So what happens is that we have these antibodies forming against this enzyme complex that happens to be in the skin. It's a similar enzyme that we see in the gut that's causing this deamidation of the gluten peptide, but it's actually in the skin. And what you're looking at is an immunofluorescent antibody staining showing the outline of those antibodies in the skin. And what you see on the left-hand side is the actual skin lesion. It can be very, very itchy, and people tend to really scratch themselves deeply, and you get these scaly lesions. And sometimes you have to give a medication or a steroid or a dapsone just to get the itching under control until the gluten-free diet really kicks in. It could be quite devastating, the itching. So what are some common facts? So here are the factors. One is that we have these specific autoantibodies that we could use to diagnose the disease. So please keep these ones in mind. One is called the antibody against that enzyme, tissue transglutaminase, that we saw in the gut, but also in the skin in those patients with the dermatitis herpetiformis. Also, there's another antibody that's called endomysial antibody, or endomysium, or EMA, and those are less commonly used. They're more expensive to do. That requires more of like a human interpretation, which can have variation from laboratory personnel. Then there's another antibody, it's called anti-deamidated gliadin protein, or DPG, which comes into play in diagnosing the condition. But as Kelly had mentioned, that there is a genetic predisposition and a genetic requirement that 99+% of patients who develop celiac disease must have either HLA-DQ2 and or DQ8 in one form or another. So you can see on the right-hand side that only 1% of these people with celiac disease will have a lack of these two haplotypes. And that becomes important because you can actually screen people with using these genetics. And if they do not have DQ2 or DQ8, chances are they don't have celiac disease. And I'll show you some examples why that is so important to keep in mind in terms of diagnosing the condition. So how do we do that? How do we diagnose this condition? Well, one thing we keep in mind is that we have these blood tests, and these blood tests are actually antibodies. There's IgA forms and there's IgG forms. IgA forms are the most commonly used. Unless one has an IgA deficiency, then we have to look at the IgG forms. And so these are called, again, the tissue transglutaminase deamidated antibody, right? The gliadin peptide or DPG, and the endomysial or the EMA. Now, what most societies require is a duodenal biopsy to make the diagnosis, because there's classic findings on a duodenal biopsy, because that's what celiac disease is affecting, the small bowel. It's causing the small bowel to become dysfunctional, to malabsorb nutrients. And that's basically why we see the manifestations that we see, right? With osteoporosis and iron deficiency anemia and B12 deficiency we can see, and so on and so forth, is because people can have this defective malabsorption, let's say, of the epithelium. We would see classical findings on the biopsies. And so most societies require that biopsy as well as the blood test in combination to make the diagnosis. So the key thing here is that people need to be eating gluten to make the diagnosis, because is that if you go off gluten and your antibodies start to come down like they're supposed to, and your biopsies get better, then you can have this false sense of security, all false negative, right? So if you're off gluten and one wants to make a diagnosis and the tests are negative, then you really don't know if you really have celiac disease. In those situations, we tend to use the genetics. So if somebody absolutely cannot come off, let's say they can't challenge themselves with gluten, then we'll use the genetics and screen using genetics. And if they don't have the DQ8 or DQ2, then 99 to 1, they don't have celiac disease. So just realize that you'll see people give what's called a gluten challenge to make the disease diagnosis. And we try to use the IgA, but also as a backup test. We have this deamidated gliadin peptide test, which is really an IgG-based test as a backup. But we try to use the IgA unless they're IgA deficient. So this shows you kind of the algorithm that experts keep in mind, and these are in the American College of Gastroenterology guidelines for diagnosing celiac disease. These came out in the original guidelines in 2013, and recently the same authors had repurposed this and republished this. But this particular slide is taken from the 2013 guidelines, which is still universally used today, is that we take a look at these genetics first. If people don't have the genetics for it, unlikely to have celiac disease, they really 99% of the time they don't have it. But if they're positive for the genetics, we have to make sure that they're ingesting gluten. If they're able to tolerate the gluten, we like to see them ingest 3 grams a day for up to 6 to 8 weeks. And at that point, we think about, okay, they're able to tolerate the gluten at that point. That's when we're going to look for blood work. We're going to look for duodenal histology with endoscopy and see if they're positive. If they're positive, then we know that they have this potential to have the disease. And so that's how we go about making this diagnosis for celiac disease. Now, this particular slide is of interest because it shows you what blood tests we use in practice. And so what was used many years ago in gray are these antibodies against gliadin. And some people use these still today to look for sensitivity to gluten, even though it's really a poor test for celiac disease. Some people still use these anti-gliadin antibodies in practice, but they really shouldn't, because they're really poorly predictive, right? You can have an anti-gliadin antibody and the predictive value of that is 18%. That's quite poor, right? So we're looking in terms of performance are these tests that are highly predictive for the disease. And if they're negative, you can feel rest assured that if someone is ingesting gluten and they have a negative transglutaminase IgA, they don't have celiac disease. So you want something that's highly predictive if it's negative and with fair certainty and has high specificity. So these two tests in both violet and also in light green are the two that we most commonly use in practice. We try to use this test here because it is the best performing test, the transglutaminase IgA. And if someone has IgA deficiency, now IgA, you say, well, now who has IgA deficiency? Well, in the US population, maybe 1%, maybe less than 1%, but in those with celiac disease, their IgA deficiency is double to triple that of the common population. So they tend to get IgA deficiency more. So you really got to test to make sure that they have adequate IgA levels if you're going to use this test, or else you're going to have a false negative test. All right, so let's talk about the next slide. We talked about what these antibodies are. We talked about what happens in an IgA deficient state. We tend to use the DPG because it's an IgG. Realize out in the, let's say, more functional or holistic world, there are companies that are trying to develop, and I call it experimental laboratory tests for those with gluten sensitivity, because gluten sensitivity, as we will discuss, is a whole different pathophysiology and is today really only diagnosed by the elimination and re-challenge of gluten, right? So basically, if you do not have celiac disease by using these tests we've just discussed, and you feel like you're gluten sensitive, then you get challenged with the gluten, you feel sick, you come off it, you feel better. That's how we diagnose gluten sensitivity today. That's non-celiac gluten sensitivity. But there are companies out there that are looking experimentally at antibodies and all these different components or breakdown components of gliadin. So realize that these are not ready for prime time. There's a small number of companies that are looking at it. We don't have really good data on it, but just for those of you who have had this done or know that these tests are out there, these are really not scientifically validated at this point to use in clinical practice. And that may come up in the Q&A as well, right? So here's the overview, is that we try to use this IgA derived test against tissue transglutaminase. It's an antibody test. If you're low in IgA and you have IgG, then we look at this TPG antibody to use for the test. Some people, if you do have IgA and you want to have a confirmatory test, they use this endomysial antibody, but it's very expensive and it's subject to human interpretation, which can vary amongst different technicians. Realize that IgA deficiency is more common in celiac disease, so we have to measure that total IgA. Haplotyping is crucial for each patient as a screening tool. If they don't have these HLA, DQ2 or DQ8, it is very likely they don't have the disease. So we try to use this for populations at risk, right? For those first degree relatives, for patients with different autoimmune conditions. So this is just showing you some data on the HLA genetic testing. We like it in clinical practice because it has a very high negative predictive value that if it's negative, we have almost absolute certainty that patients do not have celiac disease. It is not altered by the diet. So if people cannot ingest gluten for the challenge to make the diagnosis of celiac disease, we use the genetic test as a screening tool. So that's where the most common areas of practice are for genetics for a screening test. If there's any equivocation on the biopsies and or the histology and or there's discordance with the serologies, we tend to use it either as screening or in targeted populations when there's in doubt. We go to genetics. So it really raises a question, is that should there be mass screening of the US population in general? Is it cost effective? And this came up in the updated, as you can see, 2023, is that they have a guidelines committee that had the celiac experts, and the guidelines were against the mass screening for celiac disease in the US population. But they felt that targeting screening in those at higher risk was warranted. So here are the conditions, and this came right from the 2023 guidelines, which is really interesting. It's like, well, who do you screen, right? Who are those who are more at risk? Well, look to the left. Look at the number of conditions. It's legion. There's so many different individuals who have thyroid disease and diarrhea and this dermatitis herpetiformis and iron deficiency anemia. All these people should be screened for celiac disease. That's a lot of people. So to me, it's close to mass screening, but it has somewhat targeting because celiac disease is so common. But look to the right. And I think this is really fascinating that they put this in this guidelines, that they put people with brain fog. I never thought I would see a recommendation based on brain fog to screen for celiac disease, infertility, migraines, epilepsy, arthralgias. You know, these are conditions that are so many in the US population that it becomes pretty close to mass screening. But these are the conditions that they're recommending to consider and or screen for celiac disease. A lot of conditions. So we've talked a lot about gluten. We've talked about celiac, but we really haven't talked about what are the ones to avoid and what are the ones to be really concerned with. So I think for all of us who have, let's say, concerns about gluten in terms of health, look to the left. This is a really good slide to keep in mind, is that if you look to the left, there's the things you can have. If you look to the right and it gets complicated, because what is triticale and what is spelt or what is seitan? These are all different variations of farro and couscous. These are all wheat products that ultimately are high in gluten and can cause problems. So if you go out to a restaurant and dining and you have concerns about gluten, you have to understand what grains they are, what recipes they're used in, and the nomenclature of the dishes that have these different grains. You have to be very cautious because they could have gluten that can make you sick. And just as an anecdote, there is a story when I first came to Baltimore, and I went to a Harbor East restaurant, I won't say which one. And I remember there was the maitre d' was there, the head chef came out because the gentleman I was with, who was a speaker at a conference, has gluten sensitivity. His fiance is celiac, and they were up and down reassuring both of them that there was no gluten in the food. Well, they both got sick. They both got glutenized, and it was just like my first witnessed event of in a restaurant. You always have to be skeptical, no matter where you go, that there's going to be gluten in some of the foods. So you got to be really careful. And we'll talk about that on the Q&A in terms of being judicious and cautious, even at home, even with your family in terms of cookware. But here are the guidelines, ACG guidelines in terms of monitoring. We talked before about why monitoring is so important, is that, well, you could be gluten-free and feel okay, but you could still have an ongoing exposure, and that could be causing ongoing extraintestinal manifestations, osteoporosis, and other health conditions. So we need to have ongoing monitoring by antibodies, by DEXA scanning by bone densities. And one thing the guidelines are pretty clear is that there should be consultation with an expert dietitian initially, and then along the way, if there's any questions about exposure. So adherence is really key. And we try to monitor people, at least for the disease, with both, let's say, the serologies, and at times even by biopsy, to at least make sure people are in remission within 2 years of diagnosis, get a repeat biopsy. And that's in the guidelines, as you can see here, is that we try to look for mucosal healing. after 2 years is pretty much the guidelines. We look for normalization of the antibody test. And again, we really can't underscore the importance of bone density. And because this disease can really become a problem with osteoporosis. Okay, so in terms of the guidelines, here's the question comes up is that do we really need a biopsy? Do we really need a biopsy? Is that we realize that in the pediatric population, if we can avoid the biopsies, we try to do that. And so if your antibody tests are so high that they're 10 times the upper limits of normal, that if it's confirmed by 2 different types of antibody tests, that's enough to make the diagnosis without a biopsy, at least in children, and in adults who are unwilling to undergo an endoscopy. So we're trying to move in a direction which is more European, which is not needing the biopsy to make the confirmation, but your antibody tests have to be screamingly high to make that diagnosis. That's where we're going in terms of the guidelines. Now, as I mentioned before, I think it's important to keep in mind the pathophysiology because pathophysiology leads to therapy. So here we know that it's very hard to modify the dietary gluten, but once it's in our system, we can bind it. They're looking at the gluten binders to prevent the gluten from adhering or leaking through the epithelium. We're looking at enzymes that actually can digest this gluten more thoroughly. And there was clinical trials ongoing with these glutenases, as they call them. I mentioned the zonulin in detail because there's clinical trials looking at antagonizing the zonulin. So that way the tight junction regulation is tighter and doesn't allow this partially digested gluten to get in. So there's zonulin antagonists being looked at, or also preventing the deamidation of the gluten that's getting in. So you're looking at blockers of the deamidation process, and all these different inflammatory mediators. They're looking at agents that block them, like they do in inflammatory bowel disease. So understand that pathophysiology leads to science and therapies. That's why it's important to have that understanding. So what happens if you go to a restaurant? As I just mentioned to my friend who unfortunately got sick, him and his fiance, from that exposure, that the question is there a way to look through that food and say, is there gluten? Well, that's been thought of. There's something called a NEMA sensor that is currently not recommended by the guidelines, but is still being investigated as taking a sample or pea-sized piece of food and analyzing it, at least in a single-use fashion, to see if it's got any gluten products. And it's really at this point not ready for prime time. There's a publication available on it from a number of the guideline people who formulated the guidelines, did a clinical trial on it. Again, it's really not really ready for prime time, but it's currently being tested as well. And a caveat is that, the question is you need a decent exposure to really detect it by using the NEMA sensor. And maybe we'll hear through the Q&A people who have used it, at least in these clinical trials, who have actually tried it. So I think what it becomes more compelling for individuals is we've heard about celiac disease, we've heard more about gluten as something that people go on for weight loss reasons, for health reasons, and there's unfortunately much more gluten sensitivity out there in the public. 10 times more people report gluten sensitivity than are known to have celiac disease. So it would be remiss of me not to talk about non-celiac gluten sensitivity, because there is this overlap, right, between irritable bowel that we see commonly in the GI world, celiac disease we see less common unless you have expertise in it. And then we have this overlap with this non-celiac gluten sensitivity. And that it really is worth discussing. Now, as we know, wheat, there's a lot has been, let's say, written on wheat. There's been theories that the wheat has been shifting in terms of the way it's been hybridized over the years, its components, its gluten content over the years. The wheat may be different a little bit here than in other parts of the world. But we know that the wheat in particular of all the gluten grains is very enriched in these epitopes that can cause this condition. And so the wheat proteins we break down by gliadins that we've talked about in depth, gluteninins. I talked more about gluteninins in those more experimental tests that looked at the antibodies against these gluteninins. Albumin we'll talk about in the antitrypsin inhibitors, because in albumin itself, they have these inhibitors that can cause a toxicity and these globulins. So wheat has, it's kind of primed to cause a number of GI problems because these wheat proteins can be quite disruptive to the gut in the right predisposing factor. This slide shows you in particular this albumin component of wheat, which has antitrypsin inhibitors, which again can set off these, let's say, immunological reactions in the gut and cause symptoms in individuals that we see mainly in wheat. But in celiac disease and even in non-celiac gluten sensitivity, it's this, what we call this 33 amino acid long fragment of, we call it a 33-mer, that causes a lot of problems because that's the one that's really resistant to the enzymatic degradation and gets through the epithelial barrier, the leaky gut, and it gets deamidated and causes chain reaction that we've been discussing at this point in time. Now, another class of proteins I find really interesting, and I believe there will be questions on this, is the prolamines. And the prolamines, again, they're highly resistant to degradation. And the thing is that these grains have these prolamines. So the wheat, rye, and barley are really gluten-rich prolamines. But look at oats, and we know that there's concerns about oat, even though not having gluten, it's got prolamines. And there is let's say, contamination because some of these places where we have milling and they produce oats also produce gluten, so there could be cross-contamination, or that oats are rich in these proteins called adherence, and they themselves are gluten-like. And some people can be highly sensitive to oats because they have this, let's say, commonality to gluten itself. So some people have to be careful with oats as well if they have either celiac or they have gluten sensitivity. And that's very hard to predict about who would be sensitive to oats. So you can see in this particular slide that we begin with wheat higher up on the chain, and then basically the protein components of wheat itself are gliadin, glutenin, and gluteomorphins. And gluteomorphins is interesting because they cross into the brain and can produce some of those symptoms that we report with gluten sensitivity. The headaches, the brain fog are felt to be secondary to these proteins called gluteomorphins. And maybe the addictive properties that people say gluten can have is because of this gluteomorphin that gets into the brain. But in any event, it's when we using transglutaminase, is that when we have this deamidated protein product is what could cause this toxicity that we see in celiac disease. So we have some, there's been a lot of research on this by Dr. Volta and of course Alessio and others, Alessio Fasano and others, is like, what is the difference really between celiac disease and gluten sensitivity? And as you can see on the left, we have gluten sensitivity. Celiac disease is more brighter orange, like our Orioles. On the right, and somewhere in the middle, we have a combination of the two. Is that what they have in common is that they have this, let's say, response to gliadin or this protein reaction that has inflammation in common. But on the right-hand side, you can see celiac disease has things that are unique to it, like the tissue transglutaminase antibodies, mucosal damage, epithelial barrier dysfunction in both conditions. So we do know certain things about the pathogenesis that they have in common and also have that are distinct. And unfortunately, with gluten sensitivity that's not celiac related, it is very hard to diagnose immunologically. We have to give a gluten challenge and they get worse. You come off the gluten, they get better. And then basically we don't have a way in the bloodstream and or the biopsy at this point to diagnose it. Now, we know in some cases, we can see like a genetic predisposition like we see with celiac disease, not nearly 100% like celiac, maybe 50%. So it's a little bit more than the general population. If you look at the US population, about a third of people will have either HLA-DQ2 or DQ8. If you look at celiac disease, it's 100%. But if you look at those with gluten sensitivity, it's a little bit higher than a general population. But of course, not quite what we see with celiac disease. It's not a requirement to have for non-celiac gluten sensitivity. So what about gluten sensitivity and IBS? Well, we see a lot of people with IBS who do have gluten sensitivity. And why is that so? Is because, let's say, wheat itself, we know that there is wheat allergy, right? We know there's an IgE-mediated wheat allergy. If someone has wheat, they can anaphylax, they can get hives. Easy to really diagnose on a skin prick or an IgE antibody test. That we know we can do to people. But we also know we have this family of let's say, compounds called FODMAPs. These are fructo-oligosaccharide, disaccharides, monosaccharides, and polyols. These are like a family of different, let's say, foods that are very rich in, let's say, poorly digestible products that can cause diarrhea and bloating, and wheat is one of them. So people can be intolerant to wheat because it's high, it's a FODMAP. It's one of these types of foods that are very hard to break down. It has high in fructans. It can cause, let's say, fermentation in the gut by the bacteria, and they can cause a lot of symptoms. So wheat can be a FODMAP. Wheat can give you a true allergy. Wheat can induce celiac disease. And we can also provoke symptoms by non-celiac gluten sensitivity. So that's why wheat is on a lot of people's radars these days, right? And in fact, it's hard to ignore because you see all these different, conditions, one of them being non-celiac gluten sensitivity, and wheat is always at the forefront of it, right? So also, wheat has become, let's say, in the news because there's a craze on the gluten-free market. We know, and this is an older slide, they forecasted back in 2013 that by now, the market will be about $18.5 billion annually in sales in gluten-free. These are products that are dietary products. These are products you find out on the shelves. There's a very, very lucrative market for gluten-free, and Lord knows with inflation what that looks like even today. So there's also a fad. Look at all the celebrities over the years that are promoting this. Oprah and many others, as shown on this slide and not shown in this slide, have promoted the gluten-free diet. And after Bill Clinton had open bypass surgery, he went on the gluten-free diet and became a champion of it for quite some time. But we also know that we have best-selling authors who have promoted this grain-free and Dave Perlmutter's approach called Grain Brain, or Wheat Belly, which was kind of the revolutionary. It was kind of set the trend for people to lose weight, lose the belly by going wheat-free. New York Times bestseller for many, 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 many weeks, not years. And also even the South Beach promoted this. So we know people have popularized these, promises beyond celiac disease, beyond, let's say, non-celiac gluten sensitivity, is that somehow coming off wheat will magically cure all your problems, including losing weight or having no brain fog, or so on and so forth, even with the positive evidence to support that. So why do people embrace a gluten-free diet? This is a really good survey, internet-based survey in adults. But if you look at it, the majority think it's healthy. Between the media popularity and those best-selling and other books, people think it's healthier to be off wheat, and even, let's say, even a quarter, because they'll lose weight off it. So basically, people feel that wheat is this compound or this food that really should be somewhat limited, if not eliminated, in the population. But what do we know about gluten sensitivity? Where do we see it? And I have to say, I've seen patients over the years in the US who have had gluten sensitivity. They go to Italy, they're able to have pizza and pasta without any problems. Then they come back to the United States and they get sick. So is there something here different about the wheat than what we see in other countries? It could be, but we see less of it in, let's say, Italy or Argentina, which I think is kind of interesting. But going back to the brain and Dave Perlmutter's book and the gluteomorphins that I mentioned, and also those ACG guidelines that mention with brain fog that we should start testing for celiac disease, is fascinating that we've had the community think that there may be this connection. So it could be that gluten could be all these different things, that this also anxiety, depression, irritability, seizures. Is there this connection, even schizophrenia, to gluten? And the ACG guidelines look like they're moving in that direction, although they're not quite there yet, or even autism, which is quite controversial. So getting into the discussion in another minute or two, who should be on this gluten-free diet? Should it be people with just celiac disease? Should it be just people with celiac disease and non-celiac gluten sensitivity? Or do we go more toward the right, where people are claiming that wheat is this evil that should come out of the dietary part of our resources? So what do people avoid besides wheat, let's say, or gluten, who are following a gluten-free diet, but they actually eliminate other foods that could be quite healthy for them, like eggs and dairy and nuts, even though. So the message here is that people with celiac disease don't always just avoid gluten, they avoid other common allergens as precautionary, and that can cause nutritional deficiencies downstream. Next slide. So in summary, we're looking at this condition that we call celiac disease that we know is autoimmune in nature, that is caused by gluten. And therefore, if we actually eliminate the gluten, people can do quite well with celiac disease, even though they need some monitoring. But gluten is also has this other, let's say, evil twin, which can cause symptomatology, which is harder to diagnose in gluten sensitivity, and is more common in the US population by tenfold than celiac disease that we're just starting to learn about. So with that, I will thank you for your kind attention and look forward to your questions.
Great. Thank you so much, Dr. Mullin. Okay, we got lots of questions, so I'm going to rapid fire because it's 7:52. So I'm going to
Wow, I can talk.
go. Hey, but you covered a lot of the answers to these questions here. It was really, really wonderful information, completely thorough. So let's get going. So Janice wants to know, so if you spoke about that people just deciding I'm gonna go gluten-free diet. Is there consequences by eliminating gluten if you don't have celiacs or you don't have any sensitivities?
That's a really good question, because if you go gluten-free and you're doing it for celiac disease, you know that even a morsel of gluten can get you sick, short and long term. If you're doing it because you want to eliminate gluten because you think you're sensitive, you could probably get away with less of it or more of it, being exposed to. But if you're going to eliminate it altogether, you got to make sure you're getting enough fiber in your diet, because if you have less fiber from the wheat, right, then basically your microbiome can be depleted in bifidobacterium, which relies on fiber. So if you go gluten-free, just make sure you're getting enough fiber, whether it's from some of the other grains or some of your other vegetables. Just make sure that you're getting enough fiber and you'll be fine.
Great, thank you. The next question from Lisa is, will your body ever make the necessary antibodies?
Necessary antibodies
To avoid getting celiac disease?
Well, what happens is that you'll you get the disease. The question is how you diagnose it. So you use the antibodies to diagnose the disease. And there's some people who have common variable immunodeficiency, IgA deficiency, that it's hard to diagnose because they have an underlying problem making antibodies. So diagnosing those people are a bit of a problem. We rely on genetics and things like that to really screen them out. but basically the disease itself can actually lower your ability to make antibodies. So it can be a vicious cycle. And we don't know whether if you come off the gluten and your celiac disease goes in remission, how that's going to affect your ability to make some of those antibodies back. So that's a little bit of an unknown.
So you're never, quote, cured from celiacs, or are you?
That's a good question. There is no cure. They're working on clinical trials to really mitigate it and prevent people from getting sick once they're exposed to gluten. But it's an autoimmune condition like other autoimmune conditions that your body is just trained to, in this case, attack this gluten peptide that's being partially digested by tissue transglutaminase. That doesn't apparently be there is no cure for that particular. Once your body is programmed to react to it, there is no cure to undo that. That's correct.
Okay. Mm-hmm. So you did speak about, Dr. Mullin, that if you do have an autoimmune disease, and you listed them in your on your charts in your PowerPoint, that you're more susceptible to celiacs. Can it go the other way? If you have celiac, but you don't have any other autoimmune, are you more susceptible to getting other autoimmune diseases?
Yeah, it works with autoimmune diseases. It works. It's bimodal. So if you have diarrhea and have celiac disease, you got to look for microscopic colitis. If you have microscopic colitis, you should test for celiac disease. So yes.
Yes, great. Thank you. Questions from Barb. So you said you're going to touch on, and we'll do this in the Q&A, about people with celiac disease. Do they need to cook with separate pots and pans? You were talking about that at home. You talked about being out. So what can people do at home?
Yeah, they do have to have separate cookware because with celiac disease, even a morsel can set off unfortunate chain reaction. So separate cookware is essential. And I've seen families who they all just go gluten-free. Others, they do the diligence of having separate cookware. But it's difficult and challenging to do. Mm-hmm. Unless you really, it's very challenging to do. The restaurants is what I worry about.
Yeah, sure.
Because we know there's stories of gluten-free restaurants, even in New York City, that claim to be gluten-free, and it doesn't shake out that way. Yeah.
Right. Like a peanut allergy.
Got to be careful.
Yep, exactly. So our next question from Christy, she says she is newly diagnosed with celiac, and she'd like to know, where can she go for information online that she can trust? Are there any forums that she can join that are moderated?
There's a Celiac Foundation in Philadelphia. I find them to be the most reliable website for information for patients. I would say the Celiac Disease Foundation. Their headquarters is in Philadelphia. They have a number of top advisors that are celiac disease scientists.
Great, wonderful. We've got about a minute and a half, about 2 minutes. So is there any new research or treatments on the horizon that might help to better accurately diagnose or treat celiac disease? Do you see that in the future?
There's enzyme therapies that are ongoing. There is that anti-zonulin, and also they're looking at these interleukins for people with refractory disease, and even if they're off gluten, that the chain reaction just continues, and there's ways to go after the immune system and block damaging effects. So there are a number of clinical trials that are ongoing, and just too early to make any speculations.
Mm-hmm. How do you get into the clinical trials? Does Hopkins have those?
Not at present. Not at present. Mm-hmm. The foundation website has always lists them and has contact information. So I would say that would be your center hub.
The Celiac Disease Foundation?
Correct.
Mm-hmm. Okay. Well, it looks like we are getting near the end here. One more quick question, about 30 seconds. So is celiac, would you say that this is also a hereditary issue?
Yes, you can see it in families, first-degree relatives, absolutely.
Mm-hmm. So when you're going to your doctor and you're starting to have these types of symptoms, just remind them right? Wait a minute. My grandmother or my mother or my father or something, right, has celiac. People tend to forget that. That's why people, when they ask you those questionnaires in the beginning, when no one wants to fill them out, right? But there's a reason for that.
That's true. There is a
Right.
method to the madness. That's correct.
Exactly. Well, listen, Dr. Mullin, thank you so much for joining us this evening. It was really wonderful to see you again, and also for all your wonderful knowledge. And I want to thank everyone for joining us this evening. And in the coming weeks, a video of tonight's live stream will be available on the A Woman's Journey website, hopkinsmedicine.org/A Woman's Journey, under videos on demand. If you've enjoyed tonight's discussion, please check out our website, hopkinsmedicine.org/A Woman's Journey, for more information about upcoming webinars, our Health Insights That Matter podcasts, and sign up for our monthly emails. Have a great night and stay well.